more people to join. Welcome, everybody. Welcome to the webinar on eHealth, assuring better health services, healthcare access, and health literacy for the benefit of patient safety and health. My name is Konstantinos Antypas. I'm the coordinator of the BETTEReHEALTH project, an EU-funded project that is promoting eHealth in low-income countries in Africa. You will hear more about BETTEReHEALTH a bit later. And also research manager at the SINTEF Research Institute, independent research institute based in Norway. It's been, as a BETTEReHEALTH project is closing very soon its activities funded by the EU, continuing in a new structure or in a new way with more events. I'm very happy to introduce this webinar in close collaboration with the International Alliance of Patient Organizations. And in this, the activities that we had about eHealth in our project, we found a very important collaborator with very important views on the patient perspectives. And this discussion also resulted in this webinar that I hope they will find it interesting, shedding some light on the role of patients and the users in eHealth. The program today will start with Frederic Lievens, that is also a partner in BETTEReHEALTH, and we will continue to introduce the BETTEReHEALTH project, and then we'll have an introduction to IAPO, the International Alliance of Patient Organization, by Kawaldip Sehmi, and then later we will have Mike Isles, talking about strengthening the global medicine supply chain to protect patients from substandard and falsified medicines through eHealth solutions. And Bisi Bright afterwards, talking about enhancing drug safety and service delivery through eHealth and telehealth. So I would like now to invite Frederic Lievens, that is the project manager in Lievens Lackman, a Belgian SME that is partner in BETTEReHEALTH, and also Vice Executive Director of the International Society for Telemedicine in Health, to introduce BETTEReHEALTH.
Thank you very much, Kostas, and hello to everyone on this webinar. Thank you for joining. Indeed, for those of you who are not familiar yet with the BETTEReHEALTH project, I would just like to say a few words so that you know what this project has been doing. And as you heard from Kostas, we're actually rounding up the project right now. But with this activity and with some others still in the planning, we are beyond the project period, still moving on with joint activities among the partners of this project. BETTEReHEALTH is and was very much about boosting international cooperation in eHealth, especially in Africa, and also in collaboration with European organizations and initiatives. And it was an EU-funded project. And let me, these were the partners in the project, but let me immediately go to this slide where we show some of the core tasks and focus areas that we were working on within this project. And a very important one, especially under today's topic, is the fact that we were also addressing and looking at let's say, human factors when it comes to eHealth development and eHealth implementation. And human factors, that's where we were very much working with and looking at eHealth and what it means and how it works or how it doesn't work for health professionals, community health workers, but also for end users, for patients. And we were very pleased to have among our advisory board, Elos Lodzeni from Malawi, who is actually also a board member of IAPO, whom are co-hosting this webinar. So that was a very good direct link that we had with IAPO, also with the patients organization in Malawi, but also with other colleagues and patients and patient representatives in different countries in Africa and also in Europe. And that's how we were able to also make sure that we kept a good focus on, let's say, this demographic of patients and what eHealth can do for them, but also what some of the challenges are, the dangers, the problems that may arise. This is a more schematic overview of how all these activities and focus areas came together within the project. I just want to mention this was a registry that we have set up with a list of eHealth solutions and also a registry with eHealth policy documents and strategy documents. This is very useful. It has proven in our interactions with eHealth stakeholders very useful to indeed have these kinds of registries to see what is available on the market, let's say, in terms of solutions, how are they being used, how are they being implemented, and where. And also, of course, for policymakers, the policies, the strategies are very useful input for them to develop their own policy and strategy within their countries. We did set up regional eHealth hubs, and so our partners in different African countries were sort of managing regional hubs where they came together in real life meetings or in virtual meetings and workshops to share some of the knowledge and the ongoing eHealth developments within the region and to learn from each other. And this is actually has been from the start our credo within the project, that better eHealth is actually better health, which leads directly to the patient, the user. It's not about eHealth as technology and so on. It's really about how eHealth can support better health access, health literacy, health services, etc., for the benefit of the patient, and that's ultimately what this webinar is about today. These are our contact details within the project, and then I just want to say 2 words about the International Society for Telemedicine and eHealth, of which I'm also part and which Kostas mentioned. We're actually now looking to take some of the ongoing work of the project and some of the activities that were initiated within the project, looking to take them forward within the structure of this international association of eHealth stakeholders, so that we don't end up, with a full stop after the project, but rather take things forward that have been started up during the project. And so with a number of partners in the project, but also external stakeholders, we're we're looking at setting up a working group under this international association that is really about e-health, telehealth, and digital health developments worldwide, and bringing that knowledge and experience together. It's very much a networking organization, which is of course ideal for supporting that knowledge dissemination and knowledge exchange. We're also working on some specific services, and especially here accreditation of telehealth services to assure quality. Telehealth is definitely sort of within the scope also of patient-focused activities, and making sure that e-health and telehealth services are being set up as under specific quality standards. So that's basically all I wanted to share as an introduction to Better eHealth and also to the International Society for Telemedicine and eHealth. I will now hand back over to Kostas to introduce the next speaker. Thank you very much.
Thank you very much, Frederic. Now we'll go to our co-organizers, the International Alliance for Patient Organizations, and the CEO, Kawaldip Sehmi, that will introduce the IAPO and the digital health and care for patients. Thank you. Kawaldip, are you ready?
Yeah, thank you. Thank you very much. I think I'm getting used to in-person meetings. Thank you very much, Frederic, and thank you very much, Kostas. It's a great pleasure to be here with you, and I'm thankful to you on 2 occasions that you gladly helped us on the Global Patients Congress in Geneva and brought the message out there so that the world could see what we were working. As you know, we have been quietly engaged in the background with the African Medicines Agency and also the Personalized Cancer Care Alliance in the region with a view to progress these 2 projects forward. But without taking much time, I will start off by getting to the issue at Hub. So what do we want? I mean, that's the most important issue. We sometimes get confused with words in this. Basically, what patients really want is a universal health coverage which is safe. We're looking at zero harm. We're looking at quality. This is patient co-led clinical trials and scientifically co-regulated healthcare, which is absolutely brilliant. Patient preferences included. It must be acceptable universal health coverage. That it means it must be patient-centric for that particular patient's conditions and lifestyle, and community-centric and maybe culturally competent with age and other factors. It must be available in a sufficient quantity. So this is something, and in a timely manner. I don't want to wait 3 days to see my general practitioner if eHealth can make it faster. So you're getting at that drop. And I don't want to wait to see the pharmacist, physically go there 40 miles into town if I can talk to the pharmacist online and get the thing delivered to me by post. It must be accessible as well. The information-wise, make sure we have QR codes, etc., available on eHealth, and care pathways. How am I going to go there? And then that's best visualized. You will go see the general practitioner will take you there. The infographics that we produce are best suited for eHealth. There's no other way to describe a care pathway to a cancer patient or a patient with some chronic condition as to what will happen, when and where. So this is what eHealth is very good, is visualizing things. Also about disability and distance, it helps us out in that. Now we say it should be affordable. Universal health coverage should be affordable, meaning that it should be within that scope, that we should be providing eHealth to reduce the cost, the subsequent and what I call additional costs opportunity cost. If you can get most of the things sitting home, rather than you taking your children and your whole family on hours-long journey to the hospitals and things, that is an opportunity cost. You could have done better things, have them do their homework or do something else at home. It must be patient-led, and it must be involved through a health technology assessment. So we can't just have any eHealth there. It must be patient assessed and said that this way. It should be non-discriminatory, meaning the protected characteristics, age, gender, race, the LGBT, and other issues that may be there. You find that hopefully algorithms are non-discriminating. Telehealth is non-discriminating, AI is non-discriminating. But to a larger degree, we hope that is the case. And then our care, which is launched in the Eastern Mediterranean region. This is covers North Africa and South, so that's why we joined the African Union in it. What we want to say is that we want healthcare that is predictive. This means that from electronic patient records, this is where digital health starts helping us be more predictive. E-registry, this gives us timely and relevant epidemiology, morbidity, and information expectation. We can look at it from various aspects, where we are and how we are, and help us strike preemptively. It must be participatory. The e-forums and digital comms platforms allow that citizens to get involved, so could patients. It must be preventative, and most important, because we need to look at your devices, wearable devices, how this can help you out. Timely information is very preventative. We're working, and it should all be part of that, what I call low end, that primary and secondary prevention stage. And lastly, personalized. I think eHealth really helps us personalize healthcare to a larger degree, especially when you start getting genomics put in, and everything can be designed to you, the patient, in one form. The principles, I think something we must, I was involved in this with UNICEF some time back, and UNESCO on this. What are the principles of digital development? And because I've done some software engagement with hackathons with MIT, I thought I would share this with the principles in 2016, that we must design with the users. This is what patient-centric digital health is all about. We must understand the ecosystem, which means it should be very broad. It should cover everybody. You can't design in isolation and in silos. It should be designed for scale. I mean, that's absolutely critical, you know. We don't do things by little bits, you know, like a tiny app released here. Let's design for scale and speed. We must be built for sustainability. Must make sure the system is not one of this, like by version 2, 3, we have to update it. Be data driven, very important for that. Use open standards. I think this is in African context, this is very important. We want to have, we have been debating and also putting the African Union to start stamping down on this, what is accessing African markets, same way as the European Union is doing that. Nothing comes in there in form of eHealth until and unless it has got an open standards which everybody can utilize and use it, and especially make it more open resource. Yeah. Also, it must be there to reuse and improve, as you say, reiteration in hackathons that I use with MIT. We keep on doing this. We improve things. Must address privacy and security, and must be collaborative. Very important for us that it can't be done in isolation. And I like this is a better how. Again, something that from agile. Do look at the agile way of software development and software. It's something that we must get our stories right. You know, we can't have digital health developers helping us unless we know exactly how to engage with them and get our stories right. Yeah? Make sure our use cases are right, etc. are right, and we get them correctly. This again, the digital technology, the Broadband Commission, which is part of UNESCO, was set up in 2016. And the Broadband Commission looked at many things about sustainability, and then what they said was, look, this is how it's going to work. At the heart of it is the patients and mobile apps for improving their knowledge or adherence to the treatment. Starts with that. Secondly, I think most important was self-testing, digital health and self-testing. Then the SMS technology that they're talking about, this is really now going up 2 stages above, and it's really talking about WhatsApp, social media, and patient records and portals that we are there are very important in health. And then for the health of healthcare professionals, if you go around from clockwise, you have digital health will help us in decision support, so we can bring the patient perspective into it, so that it becomes more patient-centric. It helps the health professional network with peers and also with patients, expert patient, connects the platforms, helps us develop e-tools, telehealth consultations become part of it, and point of care diagnosis becomes even much more important. And then the policy makers are there. Their concern, obviously, I think from compliance side, is that you have to mitigate the fraud and abuse. This is what destroys many health systems and many e-health solutions when you don't think of this. When millions of patients' data is stolen, people will never give you data again. Disease surveillance, very good prediction for public health. We know predictive, as we have already said, it's going to be predictive healthcare. And then about also streamlining, I think this is the bottom cost that's very important. Patient data management and shared electronic records have to be in real time, and inventory and stock monitoring, that's also as part of that. That's something that the OpenEI 2016 framework we have also used. We said, what are the use cases? And you can see that we think it's very important to have that client registries, the provider registries, health facility registries, terminology services, and this all the IT vocabulary, etc. Shared health records. And then there's this layer of interoperability we call in the center, which will allow clinical systems, lab systems, hospitals, community health workers, pharmacy, and patients, all to connect in. Having said all these joyous things, I must also keep a foot on the ground, as I say, in reality, that we do think there is a highly likelihood of developing a digital divide. This digital divide has got several factors to it. Economic is one. As you know, richer areas within your communities, richer countries will have faster broadband speeds. Geographical, again, irrespective whether you're a rich area or not, if you've got high-level plateaus and deep valleys, like in Europe, then you aren't going to reach the hill farmers or the others around. How do you approach it all has to be good. And then the cultural aspect as well play in, and the social aspect of it. Migratory patterns in Africa for pastoralists mean that many of them sometimes get out of range of mobile health technologies, towers. You have to work out how to make sure you have good saturation of points there. Thankfully, many pastoral communities are now served by mobile vans, which have got on-board digital transmission systems. And in Kenya, where I've come from, we've got many of these now in the Randili North areas distributed, and they have done wonderful things with those. Then I think from the point of view of how to stratify, I think this is something that we have not discussed in depth in many of the ways we are working, is that universal health coverage can become a lot cheaper to deliver if we can stratify the population. What this means is that the healthy population and populations with high self-efficacy could be dealt at the bottom of this pyramid through self-care and through minimum intervention and advice. Then the second layer of self-care support again comes in through the digital health, and I think this is where we start looking at that. Not only education, self-checking, tracking, etc. We can do that. And then this means that if you have dealt with everything in the grays here, all that will be left in this pyramid will be 2 big tiers, and those will be the high-risk patients, and we can then use our doctors most effectively in there. And lastly, I'll finish up by saying that please do look at the Global Self-Care Federation and its work we have been doing with them for some time now. We've been trying to introduce digital healthcare into many communities and countries, and trying to make global self-care and digital healthcare as part of your WHO resolution. We are driving for that resolution, hopefully by next year, make sure the world takes and occupies that. With that, I'll stop the session and hand it back over to Konstantinos. Thank you.
Thank you very much. Next is Mike Isles, and the title of his presentation is Strengthening the Global Medicines Supply Chain to Protect Patients from Substandard and Falsified Medicines through eHealth Solutions. Mike works for 2 patient safety organizations. Currently, they are focusing on medication errors and traceability systems, regulatory challenges, and changes related to nanomedicines. And also specifically for this talk, concentrating on solutions to make the internet a safer place to buy medicines. Mike, please.
Hello everybody. I'm having trouble sharing my screen. It says multiple panelists can share simultaneously. So maybe if I click there, I'm having a problem getting to my slides. I'm not quite sure why that's happening, Konstantinos. Here we go. Give me a moment. This is here. Excellent. Okay, good. Hopefully you can hear me. First of all, can I say what a privilege it is to be part of this movement, if I can put it that way, and wonderful to see so many people online from all around the world. I'm going to be a little bit parochial in that I'll be talking about the internet, mainly from a US perspective and also from a European perspective. We all know the problem that the internet has brought in terms of fake websites. But I think the principles that I'm going to expound to you literally in the next 10 minutes, and I promise I will not go over, the principles that we're trying to expound here from a solution perspective, I think can work around the world. And I would just say that the references that I allude to are part of my slide deck. They will also be posted as I'm talking to you now. But a quick introduction to the 2 non-profit independent patient safety organizations. The first one here, the European Alliance for Access to Safe Medicines. We're working in a number of areas, specifically, as mentioned, nanomedicines, as there are regulatory challenges there. And indeed also medication errors, which I'll talk a bit about more on the next slide. But I think this organization perhaps can lay claim to pushing forward on what we have in Europe, which is the Falsified Medicines Directive. This requires 27 member states, every single prescription pack, to have a data matrix barcode, which can then be traced and tracked through the supply chain from manufacturer down to the pharmacist, and the pharmacist pings the pack to make sure the pack is authentic. That's alive and well, up and running in Europe. And again, there are similar ways of working in the States with the pedigree and also Turkey and other parts of the world. So that's beginning to come about around the world. ASOP EU is an independent pan-European not-for-profit organization, and we're all about making the internet a safer place to buy medicines. So what Kawaldip was talking about, I think, is absolutely crucial. I think there is not a better time coming out of the post-COVID period where governments have been alerted to the value of telemedicine. An interesting factor, Martino Canico, who will be joining us for a couple of minutes later, he is the European Association for E-Pharmacy Trade Group, he just mentioned en passant, in passing, oh, in Sweden, most of the consultations with your local pharmacist is done online, and then the pharmacist will dispatch the medicines to you through a delivery service. That's because in Sweden, the populations are far-flung. You have people in the country that need telemedicine, that need that link to pharmacists. So on the left-hand side, we have the ECHOMET Alliance. This is all about medication errors. We did a very large 13-country survey where we asked hospital chief pharmacists about 39 questions about what they do to reduce medication errors. What traceability systems do they have within the hospitals? Please do have a look at that study. It also has an interactive dashboard, so you compare the different questions across the member state countries. It's quite alarming. For instance, are medication errors published at a local, regional, or national level? The answer to that is largely no. That's not good enough. We've worked very closely with the European Health Management Association, and Evelyn Donahoe is online as we speak. And the two papers you see there, the one on the left and the one on the right, are two white papers calling for the EU institutions to raise awareness about medication errors. The statistics are absolutely horrific. In Europe, 163,000 deaths per year, and that's not counting all the harm. And you'll know the WHO statistic of 1 death per million of population. So medication errors is all about eHealth, because eHealth traceability systems has been proven to reduce these. Moving to the right-hand side, many will recall the issues you had from biologics to biosimilars, and pharmacists and clinicians were not prepared properly to make these transitions. Well, we don't want that to happen with nanomedicines to nanosimilars. And so we're working hard to change legislation in the EU on that. I would encourage you to go to this website. We have Elliot Weiss from ASOP Global online, and he'll talk a little bit about a Drugs Act in a moment. Notice the URL, bysaferx.pharmacy. That suffix is called a top-level domain name, and that kind of solution is relevant to every country in the world. So this is what I'm going to talk about. I'm going to zoom through these. The first one is a new act, the Digital Services Act. This is probably the most important act for internet governance in the EU for the past 20 years. Move to point 6, the Know Your Business community is all about those people who want to use the internet should be transparent. And so we should be able to know who we're dealing with on the internet. The Digital Services Act is very much focused on large online market platforms. So we were trying to extend the scope of this act to include all intermediaries on the internet. So it's registries, it's registrars, it's registrants, it's the hosting providers, it's the Google search engines. So we will get there, but this act is very important. Know Your Business Customer. As I've mentioned, this is about knowing who you are dealing with on the internet. And about 86 companies, including the European Federation for Pharmaceutical Industries Association, FPIA, signed up to try and widen the Digital Services Act. We did a good job there, and the Digital Services Act is about to be implemented in Europe. So taking the same theme, the KYBC, Know Your Business Customer in the UK, we have been asked to provide a health viewpoint. Often, if you introduce health and life and safety issues, then governments tend to pay more attention. I'm now going to move across to the US Drugs Act. So if Elliot could be standing by. So what is the potential of the US Drugs Act? This stands for the unlawful drug sellers start again. The domain name reform for unlawful drug sellers. So this, one of the key initiatives is about having a trusted flagger. So a trusted flagger is somebody like the FDA who can instruct hosting websites to lock and suspend. So if Elliot is there, I'm just going to ask him just to add a little bit more, because potentially this Drugs Act, we can all learn from it in the same way that the Digital Services Act, we can all learn from it. So Frederic, I don't know if we've got Elliot there.
Hi, Mike. I am on here, and I am happy to just talk about this a little bit. Apologies that I can't come on video, but this bill was a really interesting opportunity for ASOP Global to kind of be a leader in the space, talking about domain registration and how we can better identify those who are creating websites and making sure that if they are doing criminal activities, that they are held accountable for that. So the bill, which was introduced in the last Congress on Capitol Hill, it is not currently introduced, would, as Mike said, create a trusted notifier that would essentially notify the domain registry that the registrar that there was illegal activity taking place, and that registrar would then shut that website down within 24 hours, and then there's a period of accountability for 14 days, at which point then they would make a decision whether it would be reinstated or potentially shut down permanently. This is a great accountability measure that we hope someday will become law in the U.S. And again, it's all about making sure there's transparency. The way that we've worked through this is that the trusted notifiers are not only the federal government in the U.S. and the federal partners like the DEA and the Federal Food and Drug Administration, but also state level partners such as and local level partners. So in the US, that includes at the local level sheriffs, but also at the state level, state police and boards of pharmacy, which have the regulatory authority over the pharmacies themselves. So a real collaborative effort that we hope to see become law someday in the US.
Thank you very much, Elliot. That's great. And I forgot to mention, Elliot works for ASOP Global. ASOP EU has a memorandum of understanding with this organization, and we work very cooperatively. Elliot spends time at Congress and Senate, and also obviously deals with White House personnel as well, so pretty important. So moving swiftly on, Medicrime Convention. This essentially is the first time providing a binding international instrument in the criminal law field on counterfeiting of medical products. There are 18 countries that have ratified it, 12 of which are in the EU. ASOP EU is an official observer, and as such, we are allowed to present ideas and check the progress of this. These guys will be introducing new laws around the world. So we've asked for three things to happen: that the DSA is looked at thoroughly, that there is longitudinal market research to track in-country progress of anti-counterfeiting activities. What is the awareness of the pharmacist? What is the awareness of the doctor? What is the awareness of the public about falsified or counterfeit substandard medicines? And look seriously at introducing this idea of the top-level domain .pharmacy program, which is run by the NABP. Moving swiftly on, another idea is to have a piece of AI that automatically demotes illegal websites down to page 5 or 6. The Motion Pictures Association has achieved this with Google. It's done automatically. So any illegal streaming of Netflix or sports or whatever is immediately captured and reduced down to pages 5 or 6. We're trying very hard to do this for websites operating illegally and selling medicines. And here we are, the .pharmacy. You can learn more about this, but essentially this is something that is being managed, monitored, and measured by the National Association of Boards of Pharmacy. It's very strong in the US, and we're trying to provide this service across the world. If the public knows it goes to a .pharmacy website, let's say Mike Isles at .pharmacy, you will know that your medicines will be licensed and authentic for that part of your world, your jurisdiction. And this is our vision. Wouldn't it be wonderful if we had .pharmacia, .pharmacy, .apotheke around Europe, and that all of the public knew if they go to an online pharmacist, then they will get authentic medicines. The role of public awareness in creating demand. This was a Google AdWord campaign we ran in 5 countries. We were getting 35,000 first page search engine impressions. All types of medicines were brought, and we ran a survey. And interestingly, once people knew about the problems of the internet, then 91% would change. There's been some various public awareness campaigns which you can access. And this is very important and directly relevant. This is the European health data space. Some amendments has been put forward, which essentially may well mean that we have 2 sorts of tiers in terms of first tier patients not ordering with online pharmacies will be able to obtain prescriptions and other digital services. But there'll be second tier patients ordering with online pharmacies will not be able to access those services. So we have a joint statement that's gone through to the Parliament. And if I could just please ask Martino to talk for 1 minute, and then I'm going to close Konstantinos. Thank you. If Martino is online.
Yes, I am. I don't know if you can see me now. Thank you for the invitation. Hello, everyone. Martino Canonico. I'm the head of Brussels office for the European Association of E-Pharmacies. So I'm going to talk to you for 1 minute about this initiative, which I'm working on together with my case of view, but also together with other 7 organizations, including the International Alliance of Patients Organization. And really, the idea of this initiative, the mission is to make sure that every patient, regardless of where the patient is based, can have access to innovative digital health services, no matter, again, the condition, if with mobility issues, if with under certain circumstances such as COVID-19 pandemic, or living in rural areas. So we had an opportunity to really ensure that patients can use digital to access healthcare with the European health data space. Unfortunately, what we are seeing at the moment is that there are still some attempts to slow down digitalization, to slow down the benefits of digitalization in healthcare for patients. And this act should really make sure, we should really make sure to get it right, and to make sure that on the one hand, patients can make the most out of their health data, and on the other hand, healthcare professionals such as pharmacists can really make use of electronic prescription, electronic health record to get closer to the patient. As
Thank
Mike
you very
said,
much, Mark. Thank you, Martino.
Yeah.
That's great. I'm going to close you down there as we're out of time. So public awareness campaigns are very important. I'm not going to show you this video. It's a super video. You can see it on YouTube. It only lasts a couple of minutes. It's very, very powerful and is making great raising awareness in the US. So on that, given the timing, thank you very much for your attention.
Thank you very much, Mike. Next is Bisi, right? And the title of her presentation is Enhancing Drug Safety and Service Delivery Through eHealth and Telehealth. Dr. Bisi Bright is a consultant clinical pharmacist, lecturer, and public health manager, and she's the first vice chairman and CEO of LiveWell Initiative, a self-sustained nonprofit. Bisi? You are muted.
Well, thank you. I'll quickly share my slides now. Yes, so I want to thank the BETTEReHEALTH for eHealth initiative, BETTEReHEALTH for health initiative for inviting us for this program, and of course, being a member of the IAPO board, we are also partnering with them on this initiative. It is indeed a privilege, and we thank you very much for this opportunity. So I'll be talking on enhancing drug safety and service delivery through eHealth and telehealth. I will be sharing with us the experience that we've had. I run a nonprofit organization in Africa called Live Well Initiative here in Nigeria. And of course, we all know that telehealth has existed all along, even prior to the pandemic. And we in the Live Well Initiative had been practicing telehealth, but it really came to the fore during the pandemic because people had limited access to healthcare. So I will quickly start by defining telehealth, and then I will share the experience we've had, and then I will link this to what the Africa Union context is as regards telehealth. So telehealth is actually defined as the delivery and facilitation of health and health-related services, including medical care, provider and patient education, and health information services, etc., via telecommunications and digital technology. And so you find apps like the mobile app, the telephone, the mobile handheld sets, etc., all these things are being used to deliver different forms of telehealth here in Africa. Now, it is also the use of just what you can call telecommunications technology in healthcare delivery, healthcare information and education. And there is, I'm sure many people here are familiar with what we call telemedicine, which is actually grouped under telehealth, and that involves visuals where the patients can actually see the practitioner. So what are the benefits of telehealth? It helps to improve access to healthcare services. It helps to reduce healthcare costs. It helps to improve patient outcomes, and also to enhance drug safety, which is what I'm trying to talk about here today. We enhance drug safety because there's direct access to the patient when you don't have physical access. There's direct access. There's direct access to monitoring the patient who has that direct access to the practitioner, and it's a two-way communication, which is now a complete communication cycle. So what are the other uses that we can have for telehealth? And within the Live Well initiative, I'm talking about the context in which I have had direct exposure as a leader in a patient organization under the IAPO. What exactly are we doing? How does this relate to the patients? How do the patients benefit directly? So we look at telehealth for primary care checkups, where we can run community health outreaches at the LWI. We've run so many where you have direct access to patients, and their primary care checkups can be done. Via telehealth, you can, for example, encourage chronic disease sufferers to buy their own handheld self-monitoring kits. And so you can give a call to the patient, or the patient can just send you an SMS or a WhatsApp message giving you their data, and then you can now have a primary care checkup just simply by telehealth. And this can be done even for a whole community. You can say, for example, a particular community, they can meet in their community hall, and then they have their checks done. We have even gone to the extent of training champions, wellness champions within communities. And so that wellness champion can anchor the screening, and then we can have, by telehealth and telemedicine, a full primary health checkup for a community. So that's one of the things we've been doing. And then the medication reviews, you can do a review online of your patient's medication, take out what you want to take out, get the physician involved and all that. and so on. I'm a clinical pharmacist, so we work very closely with the physicians and we do these online reviews for our patients. And then women's healthcare. We actually run 2 different women's healthcare portfolios. We have the Women in Hepatitis Africa, which is the only women's organization pursuing the hepatitis elimination. And we've done quite a lot online. We've been able to train online women champions. We've been able to, through eHealth, we've been able to do that. We've been able to offer mental health to women, especially during the pandemic when mental health became a serious issue and there was a lot of domestic violence and so on. We were able to offer a lot of mental health interventions through our mental health physicians and so on. And we actually then set up a new initiative called the Mothers Against Domestic Violence, which started off with webinars, and the webinars were eHealth tools that helped to offer mental health counseling to women who were so far away, but through the e-portal, they could access mental health counseling and so on. And then another way that telehealth can be used, and we are using it, is patient education. So we sometimes do mark World Health Days, and this is through all online webinars. Apart from the on-site ones, we've been able to run online webinars, and many of these are done in a multimedia way in which even low literacy people can now have a counseling session done, an educational session. They can ask their questions. There was one we had at Makoko, which is a riverine community. Makoko is actually the largest riverine slum in Africa, and we run a health post there. And we were able to, because we do train interns from Harvard University at that health post, we were able to mount an online webinar where the Harvard candidate was able to interact with the women, and we had something on nutrition, and they were educated on how to balance their children's nutrition and all that. So many of these things that are done on site, we've been able to do them online and offer eHealth through telehealth. Then remote monitoring of vitals for enhanced healthcare access to patients, and for prompt patient attention. So a patient monitors their vital signs, calls in very quickly or sends in a written text message or SMS, and we are able to respond. So talking of telehealth medicine, where there is visual, not just the telephony, but there is a visual, the practitioner can see the patient. We actually offer the telehealth medicine, not just with physicians, but with pharmacists, with nurses, and other counselors. So we were able to mount up a nutritional counseling session, for example, last year when the patient got a meal plan just simply by telehealth medicine. The patient had a face-to-face with one of our nutritionists who is not even based in Lagos, based in Akure in Nigeria. That's about 5 hours away from Lagos. We were able to do that. So the patient was in Lagos, the nutritionist was in Akure, and there was a virtual visit with that patient, and the patient got a meal plan which the patient now used, and it was easy to now have a remote monitoring of that patient, and that patient is now stabilized on a very good meal plan. Then we also can use telehealth medicine for live video conferencing where the patient is at the other end. Even when a patient is critically ill, telehealth medicine can be used to make a very quick intervention even prior to the on-site healthcare practitioners getting to the patient or the patient being evacuated to the health system. So remote patient monitoring. And then I thought of the mobile health apps, which we use especially for pregnant women. They don't even have to be literate. Even low literacy populations can be given an app and they're told, press this number 1, press this 1 when you have a pain or a contraction, press this or go to the nearest health post. And so the mobile health apps have been very useful. And well, that's one area in which we have personally had a challenge because it costs a lot. And so to get those apps to the patients has been a challenge, but it's a very, very useful tool in telehealth medicine. Now I have here a few examples of the telehealth services that Live Well initiative has been running. There is a bank called the GT Bank PLC. We had during the pandemic, they had an arrangement with us where we were delivering telehealth services to over about 10,000 of their staffers all over the country. And they would just call in. If they needed a nutritionist, they knew the number to call. If they needed a pharmacist, they knew what number to call. And then we had the gatekeeper, who was actually a trained nurse. And sometimes when the patient did not know who to call, they called the gatekeeper, and the gatekeeper would refer them to the appropriate practitioner. And it was a very, very successful initiative, which fizzled out, of course, gradually post-pandemic when we resumed on-site services. And then another company which we worked with was the Banwa and Ighodalo, a much smaller company, but we did run the telehealth services with them. And then the Nigerian Ports Authority that has well over 12,000 staffers all over the country. We ran a very big telehealth service for them during the pandemic. So we are quite experienced in telehealth at the Live Well initiative, and we have our protocols. They're still there. I just cut out just a little bit of the SOPs, the scope that we cover under our telehealth, the code numbers that patients could call, and then the code of conduct for our employees, and how we link patients to nutritionists, pharmacists, physicians of different callings and so on. So I just cut out just a bit of this to show that it is already an established service that we have been running, and it's been working very well with proper protocols. This particular slide just shows a flyer, one of the flyers we printed out and circulated as an electronic flyer when we were going to run the telehealth service for the GT Bank, and how we communicated with staffers. So we did not see them face to face, but you could see there in an insert a little box in there showing the numbers they could call if they wanted to talk to a nutritionist, the physician's number, the pharmacist, the nurses, and then admin. Maybe they had an administrative challenge or they were trying to reach someone they couldn't, they could call the admin, and they could also call me as the CEO. My number was also in that flyer. So just to show you, these are real life, real-time experiences that we had in telehealth. And this particular picture is just showing the little health post that I told you is in that big slum. It's a slum clinic that we run. We run telehealth there. This is also where we train interns from Harvard University. They come all the way from Boston in the US to this little health post in that slum. And these particular people you see in the picture are, one of them is our operations manager, the others are undergraduate public health students that came in from a university in Nigeria to do an internship with us. We always post them there to learn, you know, and of course, telehealth is one of the things they learn when they come there. So I will quickly conclude by saying that telehealth is as important as physical health, and no doubt, COVID-19 impaired overall health access in many families and society at the time, and that really brought telehealth back to focus. And telehealth has now come to stay. It will always be there, and it's because it became a foremost thing during the pandemic. It is a life-saving tool. It is replicable, affordable, sustainable in all economies all over the world. And I want to relate to the African Health Information Exchange policy of the Africa Union. Although the Africa Union does not really have in place a telehealth policy, they have this health information exchange policy that promotes mobile health, e-health. And so what we are doing here at the Live Well initiative is in line with what the Africa Union thinking is also in line, of course, with IAPO, and we are really happy to be doing this. So I thank you all for listening, and thank you for the privilege. Thank you.
Thank you, Bisi, and thank you to all the presenters and also the comments we got. We are soon finishing the planned time, but we can, for those that they want, they can stay on for a few more minutes to discuss some of the questions that we have. I also have some questions. And from the audience and please, if you have more questions, you can write them in the Q&A. One question or two questions I see here, I can be like, I think they're important and connected, is that how can we support local organizations? And also there is was a question about employment plans, which can also be related to that. How and I see local organizations that can do different things and initiatives, and how we, or as researchers or as partnerships that promote eHealth, and also the International Alliance of Patient Organizations, how can we, you think that we can support both, as I said, initiatives for safe medications and safe eHealth information in general, and eHealth services, and also patient organizations that they want to start initiatives to organize patients. And it's also a thing that we saw in the BETTEReHEALTH activities, that patient organizations and other stakeholders in eHealth, they need empowerment. They also need to be supported by policymakers with specific through eHealth strategies and health strategies in general. So if one of the panelists would like to address this issue, how can we support local organizations?
I'll take that on first. Firstly, I think do join IAPO. I think it's very important for those who haven't. Please do join us. The second is we have been working with the WHO on several grounds. One was on the digital health, and one of the take-ups on that was that we should be advocating collectively as patients to our national governments to set up that institutional, legislative, legal policy standards frameworks we need to make sure that we have got high-speed broadband for all health matters. So the moment you are diagnosed with disease, you should be automatically given free access to high-speed broadband. Yeah, so that's one of the takeaways from them. Then the patient organizations themselves have to look at this from their point of view as to how can they participate in developing those resources for eHealth by putting in this perspective that we don't want to have colorful media agency designed artwork and resources. They can be simple. It shouldn't be the computer, but it's more the computing that we should be looking at. How can we have low resolution settings, and even much work can be carried out audio and infographics. So that's where we are coming from. And lastly, with the WHO meeting this year at World Health Assembly, we have formed, we are part of a new group which is looking at the health of indigenous people, and we're ensuring that we serve their needs. And this has got 20 country participation in it. Plus the EU has signed up this in its total, it is 28 plus 20 others. So they're all together 48. So let's have a look at that, how we can work on that. Thank you.
Thank you very much. Mike, I have a question for you. You mentioned working with Google to create an algorithm to demote illegal and dangerous websites. And this is impressive, both because you work with Google, but also because you implement AI, or they implement AI for that. Could you elaborate a little more on that?
Yes, I mean, it's a fascinating project. I have to say, I've been trying very hard to get people round the table to look at this. I'm a member of the Civil Society of the EU Intellectual Property Office, the Observatory, and the Motion Pictures Association and the film industry wanted to stop the wanted to basically stop illegal streaming of events and films, and this was achieved with the cooperation of Google. And I think it is eminently possible if we can just get Google to engage a little bit more with us. They're very, very helpful most of the time. But if we could get them engaged, because we do have software there that can identify identify websites that are operating illegally. For instance, if there's no prescription needed, the chances are that website will be operating illegally. So yes, it's a great initiative. It works for the film industry. We just need to make it happen for the health sector. And I'm working very hard to try and achieve that.
Thank you very much. Bisi, could you describe briefly how you have succeeded in running telehealth services in your NGO and how this is in compliance with the African Union's telehealth policy? Bisi? Did you hear my question?
Oh, was that? Did you call Bisi? Okay, yes.
Yeah,
sorry, I
sorry.
didn't know you were talking to me. What was the question, please? I'm sorry, what was the question?
Yeah, if you want to elaborate a bit on this, that you're running, your NGO is running telehealth services, and
Yes.
how this is synchronizing with the AU's telehealth policy.
Oh, thank you. I'm really sorry I missed that. Yes, the Africa Union
I don't know if it's only me, but I've lost.
has the policy on health information exchange and the exchange of the sender and the receiver. So this is encouraging health information exchange. The health information exchange policy of the Africa Union, we can continue to look for little ways of improvising the exchange of health information. Now, Kawaldip was talking about informatics and all that, but I remember I saw a question in the chat box saying, what of those who don't have access to the internet and such information? Now, for such people, we can start with little mobile apps, you know, handheld apps, the telephony, the tiny telephones, and so on. And the Africa Union policy supports that there should be health information exchange at every level within the society. So we are saying that as CSOs, we can start at a rudimentary level where a simple, tiny handheld device can be used to exchange information on health with the person in the rural setting who is low literacy. And I gave a real-time example of a pregnant woman who is low literacy, and she's given a handheld device and she's told, press this dot, and if you have a contraction, press this. If this happens, press this. No matter how low literacy they are, they can do that. So the example that we have, and that's why I showed you a picture of the setting, it's a real low income suburb, you know, where the people there are low income, but it is a real life training center. And I've also seen a few posts here. The CSOs in this meeting are requesting to be trained. I think this is an opportunity to look at how CSOs can be trained so that they can do a little more about getting better health into low-income communities through e-health that is affordable, using handheld mobile devices, the basic simple telephone, or even like I said, we do that in the Live Well initiative using Zoom. We get our Zoom devices, put the people in a room in their setting. It may be a room in the village and they are all there. We get one of us to go in there and that person is on Zoom. So we can relate with those people. So those are some of the ways in which we do the telehealth. They get up, they do a lot of learning. We use that mainly for educating them. But when it comes to consultation, we also use the same method where in that health post, one of our physicians is remotely located and can see the pregnant women who have complications and so on. So we do it in many ways, and it is really, really sustainable, applicable, and it's scalable. It's scalable and applicable in any type of economic setting. So those are the things we've been doing, and it really works. And I believe that we can have be trained. Maybe we formalize a process and train people and make sure that people have SOPs, because once you put your SOPs in place, then your processes will be measurable and scalable and replicable, because there are processes, there are steps that everybody is taking. And that's what we are doing. Thank you.
Thank you very much, Bisi. I don't know if you, Frederic, you following up a bit on questions. Are there other questions from the audience that would?
Well, I think what Bisi was saying addresses also one of the questions that was asked about does telehealth require mobile data? And I think we heard from Bisi that, well, simple telephone connection, SMS, etc., can also already do a lot of things. And then, of course, also in low resource settings where maybe in villages you indeed have this, well, like one access point where you as a group or whatever, you can have joint teleconsultations, let's say. So that nicely addresses that question. And just overall, I want to say, I think with Bisi's presentation and with Mike's presentation, it's great to see, I would say, two very important issues around let's say patient-doctor connection through teleconsultation being addressed, and also the matter of safe medicines and prescribing, etc. These are two things that are let's say of utmost importance for the patient. So very pleased that we were able to bring these presenters together, also together with IAPO as a partner in this webinar.
Thank you, Frederic. We are already 10 minutes over time. I would suggest that we close here. Thank you once more to all the participants of this webinar, and also all the presenters and also the panelists that participate in the presentation and the discussion. Thank you very much. I hope we'll see you in future activities of the IAPO and the BETTEReHEALTH. Have a nice day.
Thank you. Bye-bye.
Thank you.
Thank you, everyone, for joining.
Thank you. Thank you very much. Thank you. Bye.